Hi, I am Kyle Brown, one of the pediatric ICU doctors at Cook Children's Hospital. Today we are talking about focused cardiac ultrasound. By the end of this talk, I hope that you will understand the difference between focused cardiac ultrasound, or FOCUS, and formal echocardiography, that you will learn how to and when to use FOCUS at the bedside, and that you'll be able to obtain and to interpret FOCUS images. First of all, focused cardiac ultrasound refers to the use of ultrasound by the clinician to look at the heart. So at the same time that images are obtained, they're also interpreted, and this is helpful because it allows us to immediately put into practice what we learn from focus. At the same time, focus can easily be repeated over time so that we can see what's happening with our patient as the disease process evolves. So it's very important that we understand the difference between formal echocardiography and focus. To start with echocardiography, you can see here that echo uses a very sophisticated machine with a lot of controls. Typically, they obtain 30 different views on patients and use 5 different types of ultrasound modes. They're also usually in a nice, quiet environment where the patient is very cooperative. The patient will roll over to their left if they need to. They can take as much time as they need to get the images, and they're only focusing on one singular thing. You can see that the images they obtain and the types of modes they use are very complicated. They often use different types of Doppler modes to make diagnoses, and this allows them to look at a wide range of pathology in their patients. And then lastly, now formal echocardiography is sometimes even using 3D echo, where they can specifically look at the mitral valve, let's say, and know exactly what's wrong with the patient. On the other hand, focused cardiac ultrasound is very different. It uses a very basic machine with very little controls. Typically, we only obtain 5 different images and use only 1 or maybe 2 different types of ultrasound modes. Oftentimes the environment is chaotic and there's a lot of other things going on that can distract you from trying to get the images and interpret the images at the bedside. And also the clinicians using focused cardiac ultrasound have limited training as opposed to a long cardiology fellowship or a long technology school for obtaining images at the bedside. Lastly, focused cardiac ultrasound is only trying to answer 1, 2, or 3 questions about the patient as opposed to trying to diagnose a wide range of pathology. And so it's very important that we differentiate these two things because focus will miss a lot of different diagnoses that you may find with with formal echocardiography, and it's important that we don't confuse the two. On top of this, when we use focus for pediatric patients, it can bring on a whole new set of challenges. First of all, we have to think about congenital heart disease and how patients may have different anatomy than we expect them to have. Secondly, because our patients are smaller, it's often harder to have good resolution on the things that we're looking for. And we're using low frequency probes like you see down in this picture down here. With the low frequency, it can go a far distance, but it cannot discriminate those little bitty things that are really close to the imaging probe. And so spatial resolution can be a problem. And lastly, temporal resolution, because our patients have fast heart rates and fast heartbeats. It won't allow you to see all of the intricate details that you may see if their heart was beating slower. And I really cannot emphasize enough the importance it is to think about congenital heart disease when we're using focus. First of all, if you are concerned about any abnormal anatomy, it's important that you consult cardiology and that you take any of your images with a grain of salt. And especially if our patients are less than 12 months of age, we have to be very careful. So really, before using focus, you may even consider getting a formal echocardiography to make sure that there's no abnormal anatomy. And if you have a newborn who's in shock, then you have to suspect congenital heart disease until you prove otherwise. So especially in these patients, we really need a formal echo. So with all of this in mind, we need to develop a framework for when we should use focus at the bedside in children. So this really should only be used for the emergent evaluation of patients in more critical types of scenarios. So if patients need to be rapidly triaged to determine what unit they need to go to, or if we need to find out quickly what's going on with them so that we can direct clinical management, this is when we want to use focus. It's typically limited to specific clinical presentations in children. So in the setting of shock, focus can be immensely useful. In the setting of trauma, whether blunt or penetrating, we can use focus. And then during or immediately after cardiac arrest, we can often find out more about what's going on with our patient. But it is really important that we don't use focus outside of this scope. So we don't want to use focus when we're just looking for a possible cause of a murmur, or when we want to evaluate chest pain or syncope or some genetic syndrome. This type of exam may have a place for adult patients in these settings, but because of the challenges that pediatric patients present, we really recommend that we don't use it in these types of situations. So with focus, we're really only doing binary evaluations. So we're limiting it to specific yes or no questions. Is this pathology present or is it absent? And our mentality should be that we're trying to rule in certain pathologies and not to rule it out. So if after we do focus, we still have clinical suspicion, then we should obtain a formal echo. Or if we find abnormal findings, we should also confirm them with formal echo. And lastly, we should feel comfortable saying, I don't know. If the image is just not good enough, or if we are not able to see what we want to see, then we need to find other ways to answer our clinical questions. When considering which probe to use, we will almost always select a phased array transducer. This probe has a smaller footprint that allows us to get between the ribs, but also has a lower frequency that can penetrate through the chest. Occasionally we'll have the option to select a smaller phased array probe, and we can use this on our babies or our smaller kids because it has a slightly higher frequency that can give us better resolution. But if we're using it on bigger patients or obese patients, then typically we need the bigger phased array probe that has a lower frequency because it can penetrate to a greater depth and give us a better view through the chest. When using ultrasound, you should always think about where the probe indicator marker is on the screen. For focused cardiac ultrasound, this can get confusing because different groups of people will have different conventions for this. For example, in the emergency room, they often put the probe indicator marker on the left side of the screen because that's the way they obtain all the rest of their point of care images. But at our institution for focused cardiac ultrasound in children, we will put it on the right side of the screen, and there's no right or wrong way, but it is important to have a convention so that everyone does it the same way and so that you can teach it the same way. So for everything that we teach about in this lecture, we will talk about having the probe indicator marker on the right side of the screen as you see here. When performing cardiac ultrasound, it can be difficult to understand why the images look the way that they do. So I always recommend thinking about the image that you're obtaining in a plane of view. So dependent on the way that you hold the probe, you're creating different planes through the patient. So if we hold the probe in this direction, then we are getting a long axis view through the heart. But if we flip the probe 90 degrees so that the probe is this direction, we're now getting a short axis view through the heart. And we can even come down here to the apex and point the probe up towards the heart, and that gives us an entirely different plane. And so think about this as you're obtaining images at the bedside because it'll help you understand why the images look the way that they do. At the same time, we can get an image using the probe and we can just sweep back and forth, and it will give us very different views of very different parts of the heart. So you can see here, if we're down towards the apex of the heart, we get the view that we typically look for in focused cardiac ultrasound, where we're seeing the left ventricle here and we're seeing the papillary muscles. But as we start sweeping up, we begin to see the mitral valve, and then we can see the aortic valve. So the image that you get changes based on the plane that you have and where the probe is on the patient. Now let's move on to obtaining focused cardiac ultrasound images. There are 5 different images that we'll use for focused cardiac ultrasound, and all of these images can be obtained by placing the probe in only 3 different locations. The first location is called the peristernal window, and this window is just to the left of the sternum in the second or third intercostal space. And from here we can get both a long axis view of the heart that goes from the apex to the base, and we can also get a short axis view that cuts through the 2 ventricles. The apical window is the second location, and this window can be obtained right at the point of maximal impulse of the heart, so right at the apex of the heart. And from here, we point the probe up towards the heart so that we can get this apical 4-chamber view. The last location is called the subcostal window. This window is just below the xiphoid process, and from here we point the probe up towards the heart. And this allows us to look at the heart in a long axis view, but if we change the direction of the probe, we can also look at the IVC to determine how collapsible it is. So as we go through these images, we're going to talk about what window we're looking through and what type of image we have. So the first view that we typically try to obtain is the parasternal long axis view. So when trying to obtain this view, we want to put the probe indicator marker towards the patient's right shoulder, and we place the probe right to the left of the sternum in the second or third intercostal space. So when we hold the probe in this direction, it's going to give us a long axis view of the heart. So we're going to be able to see the heart from the base all the way down to the apex. And remember, based on the convention that we use, if we put the probe indicator marker over here on the right side of the screen, then the right side of the screen is going to correspond to the base of the heart because that's the way that our probe is oriented on the chest. Whereas the side of the screen that does not have the probe indicator marker is going to be the apex of the heart. So when we look at the image on the ultrasound screen, what we see is the apex of the heart down here, the base of the heart down here. This is closer to the probe, so it's anterior, and this is posterior. And really this gives us a great view of the left ventricle and the inflow and outflow tracts of the left ventricle. So here is the left atrium. This is our mitral valve. You can see it opening up and flapping up towards the septum. Here's our left ventricle, and then here is the left ventricular outflow tract with the aortic valve and the aorta up here. More anteriorly, we can see the right ventricle, although it's much smaller, and we don't see the entire right ventricle on the screen, so it's hard to make much of an interpretation of the right ventricle from this image. If we flip the probe 90 degrees, we now have the probe indicator towards the patient's left shoulder, and in this orientation with the probe facing this direction, we're able to get a short axis view of the heart. So if we fan the probe in the correct location, we're going to cut straight through the right ventricle and the left ventricle. And what we're trying to obtain is a view of the left ventricle where we can see both papillary muscles symmetrically. When we pull up our ultrasound image, this is what it looks like. We have the left ventricle here that's nice and round. We can see the two papillary muscles here and here. Here is our interventricular septum, and our right ventricle is more anterior, closer to the probe. And from this view, we get a great view of the left ventricle and left ventricular function. We're also able to see the right ventricle and compare the size of the right ventricle to the left ventricle, although it may be difficult to get a great view of the function of the right ventricle because it's so close to the probe and it's harder to see the ventricular walls. From here, we can also get a good idea of whether or not we have a pericardial effusion, and so this image can be useful for many reasons. When we move on to our next view, we have to put the probe in a different location. So we move the probe down to the point of maximal impulse, which is right at the apex of the heart, and we want the probe indicator to be towards the left side of the patient. So when we look at the screen, we have our probe marker on the right side of the screen, and this is going to give a typical radiologist view where we have the left side of the patient on the right side of the screen. So here is the left ventricle, the mitral valve, the left atrium, the right atrium, and then the tricuspid valve leading to the right ventricle. So when we pull up our ultrasound image, we want the septum to be right in the middle of the image and going vertically up and down the screen. This means that we're right at the apex in the right location. We get a good view of the left ventricle here, and we can see all four chambers. We also get a good view of both the mitral valve and the tricuspid valve. So this view is helpful when we're looking for pericardial effusions, when we're looking at the left ventricular function. It also helps us quite a bit with the right ventricular function, and we'll talk about why that is in a little bit. But more than anything, this view allows us to make a good comparison on the size of the right ventricle and the left ventricle. So typically, the right ventricle should be from between 1/3 to 1/2 of the size of the left ventricle. And if the right ventricle starts to get larger than that, then we consider that there may be some underlying pathology. For our next view, we have to move to our third location, which is the sub-xiphoid location. So we put the probe under the xiphoid process below the ribs, and we point the probe indicator towards the left side of the patient. From here, we almost want to hold the probe flat so that it can look straight up towards the heart. And when we do that, it gives us this image that you see below. So oftentimes we're going through the liver first. So first, closest to the probe, you're going to see the liver. And then since we're starting on the right side of the patient, the first thing you'll see is the right ventricle. So this is another way we can look at all 4 chambers at the right time. At the same time. We can see the right ventricle, the left atrium, and the right atrium. And we can also see both the mitral valve and the tricuspid valve. So here's an example image of that. Again, we see the liver up towards closest to the probe. The first ventricle we come into view with is the right ventricle, and then the left ventricle. Here's the left atrium and the right atrium. And again, we can see both the tricuspid valve and the mitral valve with this view. So this view is particularly useful to look for pericardial effusions because you're able to sweep through the whole heart and look at the entire pericardium. It also allows you to see all 4 chambers and maybe get a comparative size of the right ventricle compared to the left ventricle. You do have to be careful though, because based on how you fan the probe, you can get a smaller view of one of the ventricles, and you're really just foreshortening it, and you're not actually seeing the full ventricle in view. So really you have to be careful with how the probe is oriented when you make your interpretation. The last view that we obtain is in the same location, just below the ribs, but the probe is oriented up and down vertically on the patient, and it is pointed just to the right of the midline. The probe indicator should be towards the patient's head, and when we orient the probe this way, we're going to see the IVC in its full length. You can see that the IVC will empty into the right atrium, and this is going to be towards the right side of the screen because our probe indicator marker is closer to the heart. And from this view, we can also see the liver closer to the probe, and we can see the hepatic vein emptying into the IVC. So when we pull up our image, this is an example. You can see the length of the IVC. You can see it empty into the right atrium. This is actually the tricuspid valve and the right ventricle just below it. And then here you can see the liver with the hepatic vein emptying into the IVC. So this view is helpful when we're looking at the collapsibility of the IVC, when we want to have an idea of how full the tank is of our patient. But it's important that we understand that the aorta can easily be confused for the IVC. If we point our probe just slightly more leftward on the patient, then we may actually get a view of the aorta. And the difference is, you can see here, this is an aorta. The aorta has a much thicker wall, and the aorta is fully outside of the liver. So the liver is up here, the aorta is down below, and even though it looks like it's emptying into the heart, this is actually just the descending aorta that's next to the heart. So make sure you're looking at the difference between these two. The IVC has a thinner wall, as you can see. You can see the hepatic vein emptying into it, and you can truly see it emptying into the right atrium here. It's also within the liver, so you can see liver on each side of the IVC, whereas here you see the border of the liver and the aorta underneath. So don't get those two things confused. Now that we understand the images we're looking for, we'll talk about how to obtain those images. One of the most frustrating things can be finding the right window when we're looking for cardiac ultrasound images. So oftentimes you'll see that you need to move the probe in all kinds of different directions in order to obtain the right image. So you may have to slide it on the patient's chest, you may have to rotate it to get the right plane of view, and you may have to fan or tilt the probe back and forth in order to see what you're looking for. Oftentimes these movements are very small movements that can make a big difference in what you're seeing. And so you'll find that these small movements will help you get the image that you are looking for so you can make a right interpretation. When we are interpreting focus images, we are really trying to answer only 3 basic questions. First of all, is there any left ventricular dysfunction? Is there any right ventricular dilation or dysfunction? And is there a pericardial effusion? For the scope of practice for pediatrics, we really don't want to get out of asking these 3 basic questions. These are the only things we're really looking for. So when considering the function of the left ventricle, there's a couple of points that I want to start with. First of all, qualitative assessment of left ventricular function, or really even quantitative assessment, is only a surrogate for cardiac output, because cardiac output is not only dependent on the contractility of the heart, but it's also dependent on filling and heart rate. Secondly, the intrinsic contractility of the heart cannot truly be measured by ultrasound, because this is dependent on the myofiber mechanics. And therefore, when we're looking at the heart globally, we cannot actually tell what the true contractility is. Like we've mentioned before, for focused cardiac ultrasound, we use the eyeball method, which means that we're only looking at the heart to determine its subjective function. We're not making objective measurements of the heart. But luckily, we have found from several different studies that the eyeball method for left ventricular function actually correlates well with more formal objective methods for measuring left ventricular function. The caveats are that we need experienced users that have had practice in interpreting left ventricular function. We also should remember that it can miss segmental wall abnormalities because we're really just looking at the left ventricular function as a whole. Also, if there's poor image quality from an obese patient or a patient that's on high ventilator pressures, the eyeball method can still be effective because we're able to see the global function of the heart, and also it can be rapidly performed. We don't need to make pauses and measurements and calculations to determine the function. So for what we're doing at the bedside, the eyeball method for left ventricular function is quite useful. To help you conceptualize how the left ventricle functions, you should think about contraction in 3 different motions. First of all, the left ventricle contracts in a radial motion so that the walls move directly towards the center, but it also contracts in a circumferential motion so that the myocardial fibers move circumferentially, almost in a twisting motion to create contraction. And lastly, with the left ventricle, there's a longitudinal motion of contraction where the base of the heart moves toward the apex to pump blood out. So when we look at the left ventricle during ultrasound, we want to think about how well do the walls of the ventricle move towards the center. Also, how well do the walls thicken during systole? And lastly, how well does the mitral valve open? We'll talk more about the mitral valve and how that can be helpful in just a bit. When using the eyeball method, I really encourage learners to have only 3 categories when interpreting left ventricular function. So the left ventricular function can be normal, it can be somewhat depressed, or it can be severely depressed. Let's look at some examples of normal and abnormal LV function. So here we have an image that's in the parasternal long axis view. You can see that the probe is on the patient's left chest pointed towards the right shoulder, so it's giving us the long axis view of the heart. And here you can see the left ventricle. So the first thing to notice is that the walls of the left ventricle are doing a very good job at moving towards the center. So if you put your finger right in the middle of the ventricle, it's almost as if they would be squeezed by the walls themselves. The second thing you can see is both the septal wall and the free wall of the left ventricle are thickening during systole. And then the last thing you see is that the mitral valve is opening very well during diastole. So if you look at this septal leaflet of the mitral valve, you can see that the leaflet comes in almost, or maybe even fully, touches the septum. So the distance between the mitral valve and the septum during diastole is called endpoint septal separation, EPSS. So the endpoint septal separation is the distance between the mitral valve and the septum during diastole, and this gives you an idea of how good your LV is contracting. If you have very good LV contraction, then the mitral valve will open up very abruptly and rapidly and almost touch the septum as it opens. So you can look at the mitral valve to get another surrogate for left ventricular contractility. Here's another example of normal. Our last image was using a formal echocardiography machine. This image was obtained using focused cardiac ultrasound with a more basic machine in a ICU setting. So you can see the image quality is much more poor. You're still able to see that the walls of the left ventricle here at the septum and the free wall are moving towards the center. It's more difficult to see how well the walls are thickening, but you can see that the mitral valve is whipping open and seems to open really well with the septal leaflet of the mitral valve touching the septum. So this is another example of a normal LV. Here would be an example of somewhat depressed LV function. And the way you can tell that it's somewhat depressed is that the walls are not moving briskly towards the center. The LV is actually dilated a little bit, and then the thickening of the walls is less than what we were seeing before. Lastly, you can also see that the mitral valve doesn't open quite as abruptly, and the leaflet of the mitral valve is not fully touching the septum. This example you're seeing here is a formal echocardiography image, and this is an example of a bedside ultrasound or focused cardiac ultrasound image. You can see that the image is not as of high quality, but here is an example of a severely depressed LV. It's hard to see the ventricular walls, but you can see that they are barely moving towards the center. And our mitral valve here is just barely opening at all during diastole. So although the image is not as clear, it's still pretty easy to see that the function of this left ventricle is severely depressed. Here's another example of severely depressed LV function. This is one that's obtained using a formal echocardiography machine, so the image is a little bit better. Again, you can see that the ventricular walls are barely moving towards the center, the mitral valve is barely opening, and the walls are not thickening much at all. Now let's look at the left ventricle in the parasternal short axis view. We have the probe rotated 90 degrees, so now the probe indicator marker is pointed towards the patient's left shoulder. This is going to cut through the heart in the short axis, so we're going to see both ventricles at the same time. So as we look at the left ventricle, we can see the papillary muscle here and here, and the walls of the left ventricle are thickening nicely during systole. At the same time, the inside of the left ventricle is decreasing in size, so that if you put your finger right in the middle, it looks like it would be squeezed well from the walls of the ventricle. Here's another example of a normal left ventricle. Again, this is obtained using a focused cardiac ultrasound at the bedside, so the image quality is a little more poor, but you still can see that the walls seem to be moving very nicely and they are thickening well. The center of the ventricle seems to be decreasing in size during systole, and also the left ventricle is nice and round here. Here's another example. This left ventricle is somewhat depressed, and the way you can tell that is that the ventricular walls are not thickening quite as much, and also the size of the ventricle is not decreasing as much during systole. Lastly, here's an example of a severely depressed left ventricle. Again, here the walls are barely thickening at all, the size of the ventricle is barely decreasing at all, and it's quite clear to see that this left ventricle is severely depressed. Here's another example of a left ventricle that is severely depressed. The image quality is much more poor, but you're still able to see that the ventricle itself is not decreasing in size much and the walls are not thickening at all. Moving on to an apical 4-chamber view, remember that we are putting the probe at the apex of the heart and pointing the probe marker towards the patient's left. So here is our left ventricle. Our left ventricle is larger than the right ventricle by at least a third or a half, and also you can see that the left ventricle seems to be contracting nicely. The size of the ventricle is decreasing during systole and the walls are thickening fairly well. You can also see this mitral valve opening up very briskly and seems to be touching the septum during systole. Here's another example of a normal left ventricle. You're able to see that the ventricle seems to be contracting fairly well, although it's hard to see the walls completely. You're also able to see at the beginning of the clip that the mitral valve is opening up quite abruptly, and the septal leaflet seems to be almost touching the septum during systole. So much poorer image, but it does still seem that the ventricular function is normal. Here would be an example of an LV that is somewhat depressed in function. Again, the LV is a little bit dilated here, and the size of the ventricle is not decreasing as much during systole. Also, the septal leaflet of the mitral valve is only opening about halfway towards the septum. Lastly, here's an example of an LV that is severely depressed in function. The LV is barely decreasing in size at all during systole. The mitral valve is barely opening at all. So this left ventricle is severely depressed. Here's another example of a severely depressed left ventricle. Image quality is quite poor here, but you can tell that the left ventricle is dilated, the mitral valve is barely opening, and again, I would almost even say that it would be okay to say you're not sure with this one, but it is concerning that the LV does not seem to be decreasing in size much at all during systole. All right, moving on to our subxiphoid view. Again, we're below the ridge, just below the xiphoid process, and the probe indicator marker is pointing towards the patient's left. So we're first going through the liver, and then we're encountering the right ventricle here. More deep to that is where we have the left ventricle. So here you're able to see that the left ventricular walls are thickening well. You're also getting a good decrease in size of the ventricle during systole. It's hard to see the mitral valve leaflet very well, but you can see that it is opening up and hitting the septum, and so this would be an example of a normal left ventricle. And here's an example of severely depressed left ventricular systolic function. You can see the left ventricle is barely decreasing in size at all during systole, the ventricular walls are not thickening, and the mitral valve is barely opening. Now we will move on to discuss the assessment of the right ventricle. So we will look for dilation of the right ventricle, and just like the left, we'll also look for the qualitative function. But we must have a caveat that the eyeball method for the right ventricle is not as reliable as it is for the left ventricle. So we need to keep that in mind as we talk about function. The RV is different than the LV because it really only contracts in one type of motion, and it's the longitudinal motion or the accordion motion. So the base of the right ventricle will contract down towards the apex, and this is how most of the blood is ejected from the ventricle. So when we look at RV function, we want to look at the same things we do with the left ventricle. So how well do the walls move towards the center? How well do the walls thicken? And then we also look at something called TAPSE. TAPSE refers to tricuspid annular plane systolic excursion. And the way we see this the best is in the apical four-chamber view. You can see here that the tricuspid annulus is where this green arrow is, and it's referring to the annulus of the valve. And during systole, the annulus should move towards the apex of the heart. And the reason this occurs is because the RV is contracting like an accordion in a longitudinal motion. So if you have good RV function, then the tricuspid annulus should move very well up and down during systole. On the other hand, on this other image, you see that the tricuspid annulus is barely moving at all. And so this is one thing that could point you towards interpreting the RV function as being abnormal. The next point we should make is the concept of ventricular interdependence. Like we alluded to previously, the left ventricle has a higher pressure than the right ventricle, so the septum of the left ventricle is going to bow towards the right ventricle in the normal heart. On the other hand, if we have a heart that is abnormal, the right ventricular pressure increases and it pushes back towards the septum, and it creates a septum that is more flat. And this is referred to as the D sign, because instead of a nice circular left ventricle, we actually have a left ventricle that is more D-shaped. And so another thing that we should look for when we assess the right ventricle is whether there is a septum that is flat, because this would suggest that we have elevated right ventricular pressures. Let's look at some examples of normal and abnormal RV function. One of the best views for looking at the right ventricle is the peristernal short axis view. So we'll put our probe marker towards the patient's left shoulder at the peristernal window. We're going to look at both ventricles here. So left ventricle, right ventricle. One of the ways you know that the RV pressure is not significantly high is because the septum is bowing towards the right ventricle. And although you can't see the walls really well, you can see that they have a good amount of movement and perhaps some amount of thickening, and so it appears that the function is probably normal from this view. Moving on to a different example, you can clearly see that in this example the septum is flat. So the septum is more bowing towards the left ventricle almost, and it creates this D-shaped left ventricle, or the D sign. You can also see that the right ventricle actually appears larger than the left ventricle when normally it's about 50% of the size. And so both of these things would tell you that the right ventricle is dilated, and it's likely also depressed in function because you can see that the walls are not thickening and that the size of the ventricle itself is not decreasing much during systole. Here is another example. In this example, you can tell that the right ventricle looks quite large, and especially during during diastole, you can tell that the septum is flattening. But from here, you really can't tell much at all about the function. It's hard to tell how much the ventricular size is decreasing, and it even appears like there might be a good amount of wall thickening during systole. So from here, I would say that I can't tell what the function of the RV is, but I can definitely tell that it is dilated. All right, the other good way for looking at the right ventricle is with the apical view. So we have our probe in the apical window at the apex of the heart. We're looking up at the heart. So here is the left ventricle, and you can see that the right ventricle is quite a bit smaller, about 50% of the size of the left ventricle. And also you can see that the tricuspid annulus has good amount of movement towards the apex during systole. So this is a normal right ventricle. On the other hand, in this image, the right ventricle is actually larger than the left ventricle. And you can also see that the tricuspid annulus is not moving much at all during systole. So it looks like your TAPSE is decreased during systole. So from this image, I would say that the RV is dilated and the systolic function is depressed. Here's another example. I think it's pretty clear to see that the right ventricle is quite a bit larger than the left ventricle. So from here, the right ventricle is definitely dilated, and therefore it is abnormal. But the TAPSE in this image is quite remarkable. It looks like that there's a good amount of movement of the tricuspid annulus towards the apex during systole. So from here, it looks like the right ventricular function is normal, even though the right ventricle is quite dilated. So although it's not as good of a view, you can still see the right ventricle in the peristernal long axis view. So here we have the probe in the peristernal window and the long axis orientation. We see the left ventricle here, and then the right ventricle is up here. This is really only the right ventricular outflow tract, but one of the things you can tell is that the right ventricle is smaller than the left ventricle here. And it's also pretty clear to see that the walls are moving nicely in towards the center during systole. So this is a normal right ventricle. Here is another example, and in this image you can see that the right ventricle appears dilated, and the diameter of the right ventricle is actually larger than the diameter of the left ventricle. And at the same time, the septum appears to be flat, and it almost looks as if the left ventricle is being pancaked by the right ventricle. So this is an example of an RV that has an increased pressure in the ventricle, and therefore it is dilated. But you can also see that the walls don't seem to be thickening much, and the size of the ventricle doesn't appear to be decreasing much during systole, so it suggests that the function is also depressed. The last type of pathology that we want to discuss is a pericardial effusion, and this really is the last question that we might try to answer with focused cardiac ultrasound. Before we dive into this, I want to review some anatomy of the pericardium. So remember that the pericardium is made up of two layers. There's the parietal pericardium on the outside, and then right up against the heart is the visceral pericardium. Normally, and you can kind of appreciate here that even in normal hearts, there's a small amount of fluid between the visceral and parietal pericardium. In adults, this amount of fluid is about 30 mLs, and of course with kids, it's a little bit less. But as a pericardial effusion develops, there is fluid between the visceral and parietal pericardium, and as the pressure builds up, it begins to push against the heart. And so what will happen is that the right side of the heart that has less pressure inside of it will start to be compressed by the pressure in the pericardial space. And as the pressure builds up even more, even the left side of the heart can be compressed, and that's where you develop cardiovascular collapse. The compliance of the pericardium will change depending on how rapidly the effusion develops. So even a small amount of fluid can cause tamponade if it develops very rapidly, because the pericardium doesn't have time to stretch and to accommodate the extra fluid. But at the same time, if the effusion builds up slowly, then the pericardium has time to stretch, and even a very large pericardial effusion could not cause tamponade if it develops slowly. And so the size of the effusion does not tell you whether or not tamponade is developing and whether or not your patient is at risk for cardiovascular collapse. So instead, there's other markers that we look at, and we'll go over some of those things in just a little bit. So here's our first example of a pericardial effusion. This is in the peristernal long axis view, and you can see that there is fluid between the parietal pericardium out here, which is a nice bright line around the heart, and then you can see the wall of the myocardium and the visceral pericardium right here. So this fluid is right in between here. It's hard to appreciate it anywhere else. You can see that towards the end of the clip, it's also here more anteriorly. So this pericardial effusion seems to be going all the way around the heart. In this image, we're looking at a peristernal short axis view, and it's quite obvious that there's a good amount of fluid between the parietal and visceral pericardium here, and it gets a little bit less over here towards the left, but there is still a decent amount there, and there's also some anteriorly. Here's another example of a pericardial effusion in the apical view. You're able to see that there's fluid on the left side of the heart, around the left ventricle, and also around the right ventricle. It even appears that the right ventricle is developing a little bit of collapse during systole, and this would suggest that you're developing tamponade here. Lastly, you can see that this is a very large pericardial effusion. The fluid is coming all the way around the heart anteriorly, and there's still some posteriorly as well. And this is in the subxiphoid view, where we're able to see this fluid all the way around the heart. Here's another view of a pericardial effusion that is in the peristernal long axis view. Again, a very large amount of fluid, and it's pretty easy to appreciate here that during systole, the right ventricle is beginning to collapse, and so this suggests that you may have tamponade. Even though you can see this from focused cardiac ultrasound, you cannot diagnose tamponade with ultrasound. You really can only diagnose tamponade clinically, so never rely on ultrasound itself to diagnose tamponade, but this suggests that tamponade could be present, and you should exercise caution because the patient may be at risk for cardiovascular collapse. Here's another example of a patient that has tamponade physiology on ultrasound. You can see that during the cardiac cycle, the right ventricle appears to be collapsing. This is a peristernal short axis view. The effusion is quite large, and you can see RV collapse here. Here's another example in the apical view. Again, a very large pericardial effusion, and it's very clear that the right ventricular wall is collapsing throughout the cardiac cycle. Here's our last example. This is the subxiphoid view. We have a very large amount of fluid here. A little difficult to appreciate, but it seems like the ventricular wall may be collapsing during systole. On the other hand, the atrial wall is very clearly collapsing during the cardiac cycle. And so this is another example of an ultrasound that suggests tamponade is present, and it should be confirmed via clinical means. To summarize some of the take-home points, we really need to exercise caution with focused cardiac ultrasound given limited capabilities of the machines, limited training of the bedside clinicians, and more complexities in children. Remember that we're only making binary evaluations, so we're asking yes or no questions about pathology, and really our mentality should be that we're trying to rule in certain diagnoses. Lastly, the eyeball method is reliable with left ventricular function, but qualitative assessment of RV function is less reliable.